we go. Hi, everyone. Welcome back to Misconceptions. I am very thrilled to have this conversation today. We are going to be talking to two experts I heard present at the Jones Conference, and this discussion is going to be about sleep. And for anybody who has heard, conversations about perinatal mental health, about reproductive mental health, the emphasis on sleep is just continuing to grow, right? This is something that we're understanding more and more as a critical part of function, of recovery, of wellness. And this is going to get into some of the research, some of the data, and give you some good quality information. So before we launch into the discussion, I'd love for our guests to introduce themselves. Tenny, can you pronounce your last name for me? Davoudian. Is that
Yes,
correct?
that's
All
correct.
right, Tenny Davoudian, can you introduce yourself to the audience and let them know who you are?
Sure, yeah. I am a board certified health psychologist and I specialize in women's reproductive mental health. So I provide services to women who are undergoing infertility treatment, pregnant, postpartum, or perimenopausal. And one of my interests for a long time has been sleep, and now trying to think about sleep in the context of like women's reproductive life cycle, basically.
Fantastic. And you're located where?
Baylor College of Medicine in Houston.
Amazing. One of the locations that is doing uterine transplants.
Yes.
So
Yeah.
pretty impressive. Okay, and welcome, Dr. Glorisel González Viera. Can you tell us a little bit about yourself?
Yeah, so I'm a double board certified psychiatrist in sleep medicine. So I did most of my training back in Puerto Rico, and then I came here to Houston, Texas to do my subspecialty in women's mental health. And I had completed a sleep medicine fellowship beforehand because I was like, we need to combine everything. We need to provide holistic care for our patients. And so now I work as a colleague with Tenny at the clinic, working mostly with women who are either pregnant, postpartum, or during the perimenopausal transition.
So can I ask you how many women, well, I'll call you women, but how many physicians are boarded like you, psychiatry and sleep medicine, and also reproductive mental health? Because I think you're the first one I've ever met.
From my knowledge, I also think I'm the first one, but I never like saying that because I'm like, there's probably someone else. But in terms of having like the double board certification and doing a fellowship specifically in women's mental health, I still haven't met someone who has done all of those steps before.
Unbelievable. I admire your tenacity and like just keeping on going to school, right? Like you just keep on going. So well done. And thank you for being willing to share both of your knowledge with us today. So let's start the conversation. Maybe with Tenny, why don't you start? And I've cleared that we're going to be calling each other by our first names just for ease. But Tenny, why don't you begin with the understanding of why is sleep such a critical part of women's health in particular? What is it about sleep? I mean, it's probably for everybody's health, but what is it about women's health and sleep that is so crucial for us to understand?
Sure, yeah. We know that sleep is very closely related to hormonal regulation. And as you can imagine, while somebody's, undergoing fertility treatment, for example, if we can help them feel more regulated hormonally while they're getting pumped full of other hormones, it can be really helpful. And then postpartum, one of the main interventions that we recommend, which I know can be quite hard to do postpartum, is to get more sleep. And we explain to our patients that the part of our brains that help manage emotions really just can't do their jobs if we're not sleeping. So we can give you medications, we can give you all these other interventions, but until you start sleeping, like we need that foundation for you to start feeling better.
And what do you think, Larcella, in terms of like the what was for you the sleep hormone overlap? What was the motivation of going into learning more about that?
Yeah, it's very complicated. I just think like it just started from all patients that I treat in psychiatry had some sort of sleep disturbance.
Hmm.
And then I was like, okay, I need to understand this area better. And once I started to study sleep medicine is when I really understood, oh, the hormonal component is really interesting in its role. So for example, we know that estrogen promotes REM sleep. We know that progesterone also helps you like breathe better and it opens like the upper airway. And so that's one of the reasons why women have less rates of obstructive sleep apnea when we're younger, and then in perimenopausal transition, and that can change.
Hmm.
So I started to understand like, oh, there's some hormone mediated differences that start to happen once we get to be an adolescent. that we can see. And then that's going to cause an impact through our life because we're constantly going through hormonal changes.
So we're backing this all the way up to childhood. Are we backing this all the way up to adolescence and puberty? And that's where we begin to see. And are we saying that the dysfunction is that there's a sleep dysfunction and that results in a hormonal shifting? Or we're saying hormones are the ones that are causing the sleep dysfunction, or is it bidirectional?
It's probably going to be bidirectional at the end of the day. We haven't seen any differences like sex-related differences in childhood per se in terms of sleep parameters, but we start seeing some differences in, for example, the sleep spindles during non-REM sleep in females compared to males. So we do start to think that once adolescence hit and we start seeing estrogen and progesterone come like more importantly into play and having those variations during the cycles, we start to see some differences in how females are sleeping compared to males. And
Interesting.
yes,
Go ahead, go
yes.
ahead, go ahead.
No,
Continue what you're
I
saying.
was just gonna say that in terms of like how it's all correlated, I think we just don't have all the information yet. We've definitely done more research in the last couple of years, and we're starting to understand a lot of the research was done in like perimenopausal population, but we don't have as much research done in the pregnancy population. So I think there's just lots to be studied in this area to be able to understand better how everything's correlated.
Hmm. And I guess one last researchy kind of question, well, not one last, but another research question that I would ask you is, are we considering that there may be something like genetic, like there's a predisposition for women who, for let's say girls into womanhood who have, who have these natural hormonal changes, that there's something that a subgroup of women have a more complex relationship with sleep, or we're not sure, or it's more circumstantial?
Yeah. Well, in general, if you have like family genetic predisposition to insomnia, and that can be for various reasons. We still don't know what are
Hmm.
all the genetic components that can affect insomnia. There's like various theories about it. But in general, if you do have that genetic predisposition, it's more likely that you'll develop insomnia particularly. But then on top of that, um, as a as a female, we know that when we get pregnant, for example, and we start having brain changes related to the hormonal changes that are happening, we know that that can impact how our amygdala works and that can impact our sleep in general. And the way I explain it to patients is like your brain is now trying to make sure that your baby is good and alive. And so your brain is modifying itself to make sure that everything is okay. So that makes you more hyper alert. And so we know that in general, women are more predisposed to have insomnia. And it's likely because our brains completely changed during pregnancy just to be able to keep, being aware of this baby and keep this baby safe.
Oof, which makes you also understand a little bit more about why the anxiety can be higher and the worries that come along with it. Tenny, I'm wondering if you would talk a little bit more about what we hear in terms of the distress of women who are having a hard time sleeping. I think it's one of that like kind of that frustration building, that feeling of like this is never going to get better. What are the things you're hearing? Talk to me a little bit about like the psychiatric profile.
Yeah, insomnia can be highly, highly distressing. It can impact negatively so many aspects of women's lives. And oftentimes, Glorisel and I run a sleep group together for women. We do hear that women come in to see us and feel hopeless. They've tried everything. Also, sometimes they feel very isolated. They feel like their partner just puts their head down and falls right asleep, and here they are up all night struggling. It can feel like a huge loss of control, like a loss of competency, right? This idea like I can't manage my life because of the sleep issue now.
Mm.
It can lead people to socially isolate. Like if they don't sleep well overnight, they'll cancel all their plans the next day, or they won't
Really?
go exercise the next day. And so it can lead to just so many, it can take so much away from people's lives, basically, insomnia.
So it's not just I'm so tired, I cancel my events the next day. It's I feel despair and
Mhm.
therefore like I just don't have any motivation anymore to go to the gym or to or to meet up with
Right.
my friends. Oh, interesting.
Right. It's just multifactorial how much it'll impact somebody's motivation, willingness to basically engage in life.
Ooh, that's so interesting because I think we talk about sleep as more like if you have good sleep, you'll feel better. And it's not really understanding when the sleep is unavailable, like really clinically unavailable, how much distress and despair that can cause somebody. So if we're looking at it hormonally, so that hormonal changes might be something that causes a lack of sleep or less sleep. I guess I always considered it as a matter of like, you're just uncomfortable, right? Your body is growing, like they always talk about the beached whale effect, right? Like you're just not comfortable enough to fall asleep. But you're describing this as a little bit hormonally relevant, that the hormones are what's causing change. Talk to me a little bit more about it. Either of
Yeah.
you.
Like I said, I don't think it's fully understood yet, but we know that both estrogen and progesterone promote better sleep. So they're gonna be able to like increase total sleep time. Estrogen in particular, it's gonna help promote REM sleep, and progesterone in particular is gonna help promote non-REM sleep, which is that it includes that part of deep sleep, which we feel a little bit more rested. And so when we go through changes, even during the cycle, I don't know if some of the women who might be hearing it, they can say like, oh, right before I get my period, I get really bad insomnia, right? Because you're having those drop on both of those hormones. And so suddenly you're not sleeping as well. So that can be one of the reasons of how the hormonal component of progesterone and estrogen are playing a role. But also at the end of the day, I always say like everything is very holistic. So we know that there are many other hormones that are also playing a role on sleep, and everything is interconnected. And I have like a diagram from a paper that I show the patients when we do our groups. And I kind of tell them everything in your body is kind of running on its own clock. And sometimes trying to get some sleep is just feels really hard because you're trying to synchronize all the clocks and it just kind of feels impossible. So I just think it's a really complex process, but we do know that it is affected by hormones, but hormones is not like the only thing that's ruining how we're sleeping per se.
So Tenny, when we're talking about, sleep, how we're defining it, could we define it in a non-clinically medical term, meaning like REM sleep or non-REM sleep? But when somebody says, I'm having a hard time sleeping, as a therapist who works in this space, what are some of the things you're asking? Like, what are some of the questions you're asking to differentiate between like, I had a bad night versus I actually have a chronic sleep problem? And I think part of that, I want you to talk about what's normal and where we have a problem.
Sure, yeah, that's a great question. Because, how people define insomnia really varies, right?
Hmm.
We see patients who come in who completely meet all the diagnostic criteria, right? This is chronic, it happens more nights than not. They have a hard time either falling asleep or falling back asleep or both. And it's starting to really impact their daytime functioning. And then we have patients who come to us who perceive their condition to be insomnia.
Hmm.
Now, as providers, we don't necessarily argue with that, but for our own not like knowledge, we want to see are they clinically meeting diagnostic criteria or not. For patients who aren't, I think it's a lot of work around their cognitions about sleep, their expectations around sleep, and helping them kind of realize that it's actually maybe not as big of a problem as it might seem or it feels to be. And I think that's why we do it in a group setting too, so that patients can see all the whole gamut basically of insomnia
Hmm.
from very severe to none at all, but thinks that they have insomnia. And so that tends to be helpful.
So what is normal? Like what do we say is this is normative sleep patterns? Like I feel like as we expand through pregnancy, it's normal to have more disrupted sleep, but as long as you're mostly rested and you can catch up an hour, half an hour somewhere else, we're kind of like you're good. But what is considered normal for other ages or other time periods in any person's life? What's normal and what's abnormal?
Yeah. Well, we have some individuals who are what are called short sleepers, and they do fine around 6 hours of sleep. That's all they need. And just because they're not getting more than 6 hours doesn't mean they're being harmed in any way. And then we have individuals who are known as long sleepers who need maybe close to 8 or 9 hours to feel refreshed the next day. Also, how much sleep we need really varies depending on how active we are during the day, right? If we have a desk job and we're sitting all day, we might not need as much sleep as somebody who maybe works, a very labor heavy job and is, on site all day long doing something like construction,
Hmm.
for example. So defining normal is hard because so much of it is depending on our life circumstances and
And
our
when we
age.
Right. Well, that was the other piece of it is like, there's an expectation that things will change when we get older. Is the expectation that we're also going to need more sleep or less sleep, or it's still individually dependent?
In general, as we get older, our sleep is going to become more disrupted and it's going to be shorter. So that's kind of like the expectation. And I think that can be really hard because if you were like a really good sleeper, sound through the night, and then you're suddenly like waking up, that can be distressing. So sometimes one of the things is just like, let's just explore what's kind of acceptable at this point, and are you still able to do the things that you need to do during daytime? One of the, I think, more common myths that I hear from patients is like, I shouldn't wake up at all during the whole night. And that's one of the things that we tackle a lot. I usually say anywhere from like 1 to 3 times, it's okay. And if you just have to like go to a restroom and you go back to your bed and you're able to fall asleep within 15 minutes, then that's not bad at all. It doesn't affect the gross amount that you slept overnight that much where it should be so detrimental to your sleep. I just think that when we start fixating on like, did I get an exact amount of hours? Did I not wake up at all during the night? That is when it can start becoming really, I guess, distressing for people.
So do you agree with the idea, like where people will sometimes have these like Fitbits or Apple Watches, the things that are tracking our sleep? There's a ring now, right? The Aura ring that tracks your sleep. What are your thoughts on those devices? Like, does that help you? Oh, it gives us information, or does it increase anxiety around like, whether this is a good idea, whether I'm getting enough sleep? Tenny, what are you seeing that psychologically? What do you experience of your clients?
It could go either way. For some of our already anxious patients who are kind of rigid in their expectations around sleep, it can be harmful.
Hmm.
And Glorisel and I have had experiences where people print out pages and pages of data from their, Fitbit or, their Aura Ring to bring to our group to show us things. We're always there to listen and look at it, but I think it can increase anxiety for some. For others, maybe it might be helpful. For those who are sleeping fine but don't think they are sleeping fine, that might be what they need to see in order to kind of shift their perceptions so that they understand that maybe they don't have clinically significant insomnia.
So interesting that like I guess I'm one of the things that's coming to my mind also is like there's people that I'll meet, even a certain family member of mine who will say, I don't need that much sleep, 4 to 5 hours, I'm good. The question is, do you believe the person? Like, do you as clinicians and psychiatrists and people who work in this space, you're like, it's not true, you actually need more sleep, but you're just not getting it, and it's impacting your cognitive or long-term health. Like, what are your thoughts on when somebody who's like, I only need 3 to 4 hours a night. What are your thoughts? Or 4 to 5 hours a night? What
Yeah.
do you?
That's really little sleep overall. Like Tenny mentioned, there are some people that are short-term sleepers, so maybe they with 5 hours, 6 hours, they would be okay. But most people are gonna need a little bit longer than that. There's some studies that have shown maybe around 7 hours is like the ideal number for most people, and people that sleep more than 9 hours per total 24 hours, they tend to have actually like higher morbidity and mortality. Even people that take a lot of naps can have that as well. And of course, this is when we're talking about like not people who have other sleep conditions, right? So I'm not
Mhm.
talking like if you have sleep apnea or if you have like narcolepsy, that will fall under a different umbrella. But in general, I always say like 7 hours is the number that most people should be aiming for. And then there are conditions that maybe people sleep really little, feel really good, that from a psychiatric perspective, we get concerned about. So in general, I say let's aim for around 7. I think that's like a healthy number where it doesn't feel like too much or too little. But also we gotta see how each person is, right? I think like
Right.
there's so much variability in each person.
Do in perinatal mental health, we tend to talk about like 6 hours, like we're just trying to get mom to have 6 hours of consecutive sleep, 6 hours of contiguous, non-interrupted sleep. If we can take one or half feeds away from her, then she can get 6 hours of sleep. Where is that 6 hours coming from? Do we know like, is that a number that's rooted in data?
So I think that number comes from thinking. Usually I tend to say actually like 4 hours of continuous sleep. I think 6 hours would be great. It's like better,
Sure.
but 6 hours I think it's pretty hard if you have a baby waking up in the middle of the night and you want to like either breastfeed or something like that. I think in part it comes from the data of like how long it takes to go through like a sleep cycle. So it's
Okay.
usually about 90 minutes. And so if you do like around three
Mm.
hours and you give a little bit more, in theory, at least you would have completed like 2 sleep
To sleep.
cycles.
Oh, fascinating. Okay, so there
Yes.
is rooted in something interesting. Okay.
Yes.
Before I get into, I want to hear a little bit more about your study because I really found it very interesting that people would come to a group practice, environment or groups, a support group environment to talk about and to work through this process of sleep. And the protocol was really fascinating to me. One thing I want to talk a little bit more about, though, is the current research that's out there relating to longevity and memory loss. Like, I feel like every other day there's another study that comes out, valid or not, about like, and if you sleep well, then these are the benefits. And if you don't get good sleep, there's really long-term cognitive memory, life, so many health issues. What do we know to be true as much as we can, prove it? What do we know to be true today relating to the value and necessity of sleep in terms of longevity and health for all people, not just women? Who wants to take that one? Glorisel,
My
you want to take it? Go for it.
No,
my thing is,
yeah.
Okay.
at the end of the day, these are correlational studies. As far as I'm aware, we can't pinpoint one factor that leads or prevents some of these conditions. So we always try to keep that in mind. Something else to keep in mind is that might be very accurate, right? What we're reading and seeing might be very accurate. And thinking about that when you have insomnia is not helpful.
Got it.
So you're basically losing hours of sleep thinking about how many hours of sleep you're losing. So like it just
Right.
works against us basically.
And if we
Um,
weren't thinking about those with insomnia, just in general, what do we know about the value of sleep? Like why is sleep so protective and important to us? Or like, what are the things we know that lack of could result in problems?
Yeah. Well, in general, we know that during sleep, we have like memory consolidation, which I think is why probably like there's some studies correlating it with dementia down the road if it doesn't happen. We also have like restoration of the body, like our lymphatic system also like cleans itself overnight, and that is one of the things that's associated with like how many plaques, for example, accumulate in the brain in the case of like Alzheimer's disease. So a
Mm.
lot of things happen in the body that kind of like helps I guess like reset itself overnight when we're sleeping. And so this is why we think it's helpful to get sleep. So in general, again, I do think getting like around those 7 hours would be good for like cardiovascular health, for memory issues, for even mood. Like we know that the like insomnia or like really, really poor sleep can cause different things in terms of like more depression, more anxiety. Even in some very severe cases, some psychotic symptoms could develop when sleep is really, really deprived. So the studies are there. We always like I take everything with a grain of salt because I always say like correlation does not equal causation. But we have enough data, I think, both clinically and from research to know that sleep is important and that we should try to at least give ourselves a healthy amount of time to sleep and prioritize. Because what I find that people do is that if you need to do a lot of stuff during the day, I think the one thing that we're always willing to sacrifice is sleep. And
Mm.
so that's the one thing that I always tell my patients. I'm like, that's something that we shouldn't be sacrificing so willingly. We
Mm.
should sacrifice maybe like 30 minutes of a TV show, but not necessarily, 30 minutes or an hour of our sleep because we know like it's healthy for us in general.
So are you hearing in today's society, which I think was so deeply impacted by social media? I'm not going to talk about what they're talking about on social media. I'm just talking about social media itself, right? On the phone and the distraction of media. Like, how much are you noticing that media, let's keep it at media, is causing sleep deprivation, is really impacting the function of clients that are struggling with like kind of downshifting at the end of the day? What is your sense of like, is this like as big of a problem as I feel like it is, or is it like actually most people are navigating it? What is your sense of it? I would say Tenny. What do you think about that?
Yeah, I would say it's absolutely contributing to some of the issues that we see happening right now. And I recently had an opportunity to travel to another country, and they only have free Wi-Fi starting at midnight, going until like early morning. And so I was learning from their psychiatrist that the whole young population stays up all night, basically, because that's when they can get on Wi-Fi. And then they
Wow.
miss their appointments with psychiatry in the morning as a
Oh, how
result.
fascinating.
And so I think it's seeped into our culture so heavily. It's like, let me read one more news story. Let me look up one more video. It's just so easy to stay on it and lose track of time.
Yeah, that's the algorithm that they have successfully manipulated to keep us engaged. Um, let's talk a bit about, I want to get to sleep hygiene and sleep habits, but I really want us to talk about your study. I think it was so interesting. Which of you would like to talk about, like, what is this study and group process that you're doing, and what are you learning about the process?
I can talk a little bit about it. So we are currently recruiting and treating women who are perimenopausal because, like we mentioned earlier, that is a really high risk time for women to develop insomnia or experience exacerbation of insomnia. And part of the reason are those hormonal fluctuations that Glorisel mentioned. So we recruit these women. We provide them with what's called cognitive behavioral therapy for insomnia, which is an evidence-based treatment. We do it in a group format for various reasons. Like I mentioned, it's good for patients to see other patients who have it so they don't feel so isolated. But it's also good for patients to encourage each other. And what we're doing is we're doing pre and post tests. We want to see how they're doing with their anxiety, depression, and their verbal recall, which is a huge issue during perimenopause, before and after the group, to see if there's any changes.
Hmm, fascinating. And so the study that you did before that have you ever done studies with pregnant women, or because of the IRB concerns, you just can't get to do any of those studies?
Our goal is to eventually do those studies in pregnant women. Like I would love to do it, especially because it's an area where we need the research. But right now, we haven't done it. In part, it's going to be a little bit more challenging to make sure to get it approved by
Yeah,
IRB.
yeah.
Mhm.
And so what are the things you're learning? What is the strategy? It's a CBT approach, but tell me a little bit more about the strategies of the group. What's the intervention? Tenny,
Yeah,
why don't you give that to us? Yeah.
there's a few main ones, right? There's a couple of things that were anchored around. One of it is making sure you're not in bed unless you're sleeping. What we want to do is we don't want the brain to associate bed with stress and tossing and turning and feeling frustrated. We want the brain to only associate the bed with rest and sleep and safety. And so we ask patients to get out of bed if it's been around 15 minutes and they haven't fallen asleep or fallen back asleep. And it can be really hard to do this intervention, but it's so effective. We
Hmm.
just need the brain to pair the bed with rest. And the only way to do that is to not be in bed doing other things. For some of our patients who have really long middle of the night awakenings, what we do is we calculate how much time they're sleeping. And we basically push their bedtime back to squeeze out the middle of the night awakening. So some patients may be getting into bed at 8 p.m., waking up at 7 a.m., but only sleeping 5 hours during that time. So what we do is we push their bedtime back, which again is not easy to do. It's not easy for anybody to stay up that late. But again, we see that it's highly effective and pretty quickly too.
Hmm. So we'll push them to like 10, 11 o'clock at night, 12 o'clock at night. They're falling off their feet. They're so tired. And we're finding that just kind of like that shifting of when you're going to bed is really giving you more complex sleep, like better sleep in a compacted amount of time.
Yes, it's less interrupted. And then what we do is people start falling asleep easily. We back up that bedtime. So instead of now your bedtime being midnight, it's going to be 11:45, and then it's going to be 11:30, and we'll see
Mhm.
where the patient can still hold that good sleep.
And one of the things that I've heard over the years is like that the early part of the evening sleep is better than the later part of the evening sleep. So tell me how that aligns with the idea of like pushing it to late night versus like actually we're going to put you to bed at 8, but we're waking you up at 4. Like how does that work?
Yeah, I think when people talk about it, it's because they're thinking of deep sleep, and deep sleep tends to happen more robustly in the first half of the night. So in general, sleep is going through these cycles, right? And we have like N2 and N1 and 2 and 3 and REM sleep. N3 is the deep sleep, which is what people describe as like the really restorative, really nice sleep, where basically you almost cannot like wake up, right?
Mhm.
Like that's the part where it feels really, really good. And REM sleep, it's when you're having the dream. So many people, when they wake up out of REM sleep, they kind of like, oh, I remember the dream. And maybe they're not feeling as rested because REM sleep, actually, the way that it looks in the brain waves is very, very similar to when we are awake. So what happens is that during the first half of the night, we do tend to have more of that deep sleep. And I think that's where people like get that data from.
Mm.
And then the second half of the night, we have the REM sleep. But overall, that starts when you actually fall
When you go to
asleep.
bed.
So
Okay.
yeah, so it's not gonna be like, oh, that sleep is just gonna happen at like 9 p.m. And if
Got
you
it.
lost the 9 to 11, then you're not gonna have the deep sleep. So it just starts when you actually
Mhm.
fall asleep.
Why does the body do? It's fascinating as you're describing it. It sounds like that the high quality sleep is the earlier and one, two, three, and then we get REM and you're like half awake. Why is that? Why would the body do that? What do we need that for?
That's a great question. I think that's a question that we're gonna have to keep studying through
Okay.
time, because to be honest, we just don't understand fully yet why we need sleep and everything that happens in sleep.
Mm,
So I'm sure that there's stuff that's happening on REM sleep that we're still not knowing that it's
mhm.
happening there, but I'm sure that it's important, right? Because if it's happening, there must be a reason that our body is needing that.
Yeah. Yeah.
Yeah.
That's interesting. So what are good sleep habits, right? If I like Tenny that you said, sleeping, the bed is for sleeping, and I think most people are bringing their phones to bed. Some people are bringing iPads, they're playing games, they're reading books, they're watching movies. So that immediately is to me like a red flag of like, wait a minute, we have a problem here because if bed also means play or distraction or lots of light, then it might be a little bit more difficult to convince it to fall asleep. So, what do we know about that?
Yeah, absolutely. We want that association to be strong. We just want your brain to look at the bed, get into bed, and know that this is only where I sleep. I always tell my patients, like, you don't get into the shower to eat a sandwich. That's not what the shower is there for. That would be
True.
strange to do. So we need to think of bed kind of similarly, right? It has a function. We don't have to do it in bed. Even if patients have a chair in their room that they can sit on, that's even going to make a huge difference. And
Hmm.
something else that we ask patients to do, kind of going back to hygiene or good sleep, is if they're having a hard time to, at least for a couple of weeks, wake up at the same time every morning, that just really helps anchor so many things and regulate some of those hormones like we were talking about, so that patients can then fall asleep easier and maybe get back on track easier. So if you're not waking up at the same time every day and you're having a lot of insomnia, it's going to be hard to get back on track.
So, like you're saying, like when you have a weekend and normally you could sleep in till 9, 10 o'clock, you saying get up at your regular 6, 7 o'clock hour to try to set your body into a routine.
Yes,
Okay.
yes.
What?
Remembering that it's temporary though, that you won't have to do this forever, but
So
at least for a while.
you don't feel like it has to be forever. You don't feel like that's a behavioral change that's going to be critical in order to consistently manage sleep over time.
Insomnia tends to be chronic, like other mental health issues. So for some people, it's more about like keeping an eye on things. As soon as starts to slip, then they can reset it. Our concern about keeping it forever is people just won't do it.
Okay.
As humans, we just don't like that.
Got it. Okay. And I just want to clarify, do we have a diagnosis in our DSM relating to lack of sleep?
Yeah, we do have an acute insomnia and a chronic insomnia diagnosis. And we also have the ICSD also has a diagnosis for insomnia as well. And it's
Interesting.
interesting because the criteria is kind of similar, but the ICSD has like more a little bit extra criteria in there that kind of accounts for like daytime symptoms of sleep, such as like fatigue, concentration difficulties, mood changes, behavioral changes as well.
And what does that acronym stand for?
So that is the International Classification of Sleep Disorders, if
Oh,
I remember
interesting.
correctly.
Okay.
Yes,
Okay.
yes.
Interesting. All right. Give us some other feedback. What do we do to create good sleep habits? So bed is for sleep. I've also heard people say bed is for sleep and sex. Do we?
Yes.
Okay. So sleep and sex, we don't have to go find another space to do that. So we have bed is for sleep and sex. What else? What other things would you be like? I wish all people knew. Let's focus in on women or perinatal or postpartum women or just in general, but what are some of the things you just wish people understood about good health hygiene when it comes to sleep?
I think the most important thing is having a similar bedtime and a similar wake up time throughout. We did talk, it doesn't have to be super rigid over the weekends. Usually we've seen like maybe an hour of difference for the weekends from what you do during the weekday. It's not so bad. But in general, I wish everyone kind of like stick to like a somewhat similar schedule throughout the week because those like drastic variations can cause a lot of impact. And then also trying to do like relaxing stuff and not electronics in bed. I think for me, that's one of the things that's very important. We know that blue light has an impact on how you're sleeping at night and it can delay your sleep basically. So we want to avoid that blue light screen at night, and even the glasses and everything, they don't necessarily seem to be that much more helpful. So
Yeah.
if we can avoid it, I would do that. Sometimes I tell my patients like just read like a regular book with like a night light that's just directed at the book, not at everything else. That might be a little bit helpful. But
Mhm.
those to me tend to be like some of the most important things. And then the eating of fatty foods or things high in carbs. I wouldn't do that close to bedtime because that's gonna affect things.
What's close to
Um,
bedtime? Give us like a number.
for me, at least anything 2 hours before bedtime is close to bedtime,
Okay.
basically. Yeah.
And what's the reason? What is it about those foods that, I mean, I can imagine but I want to hear it from you. What is it
Yeah,
about those
yeah.
foods?
You're gonna have like the stomach acids. Maybe you can like if in a person who has reflux, it can be affected as well. And also like you want your brain and your body to be preparing for sleep and not to be trying to digest food, right? So if your body is occupied doing something else, it's not gonna be doing what it's supposed to be doing to help you sleep.
Fascinating. Tenny, what are your thoughts? What are some of the things you tell people?
Yeah, I tell people that for some people, naps exacerbate rather than help insomnia, just because I liken it to eating a huge snack right before dinner. You're not going to be
Mm.
as hungry for dinner. You're not going to enjoy dinner. And so for a lot of our patients, we ask that if they feel safe to not take naps. Now, if you have to take a nap for safety reasons or, you're just feeling exhausted, we recommend that it's short and that it's before usually like 2 or 3 p.m.
Okay. And what are your thoughts about like background noise? This is one of those things that I'm not talking exclusively about white noise for babies, because I'm sure that that's its own long discussion. But just in general, I find like some people have radios playing or podcasts playing, and that's like, I even just saw a new device that you can put under your pillow and only you can hear it, and like almost like promoting this idea of you can listen to something as you're falling asleep or relaxes you. What is the research on that, or what do we know about that?
Yeah. I read a meta-analysis on background noise, and it seems like the data is again all over the place. I don't think it has been studied enough to support like using it consistently. I think something happens for us when we do like a behavior and we associate it with bedtime, where it just like our brain
Mm,
thinks if I do this, this is bedtime. So for example, like it can be like if I hear rain, it's time for sleep. And your brain kind of like associates that automatically, and it's easier for you to fall asleep. And then if you don't do it, you're not able to fall asleep. And so an example of that's something that shouldn't work, but worked is when I was younger, I wouldn't fall asleep without watching a Golden Girls episode. I would watch a Golden Girls episode and then I would fall asleep. And that's watching TV is not what you're supposed to do, right? Prior to going to sleep. But it helped me. As soon as I watched that episode and it ended, I was sleepy, So it's something where my brain kind of associated the show with going to sleep. And I'm sure if I put it now, if I'm in bed, I'm gonna like I would end up feeling sleepy too.
sure.
Yeah. So for now, we don't have like strong data in favor for it. What I do feel is like if for some people they feel it's helpful and it's not hurting their sleep, they're not complaining like this is causing more sleep disturbance, I would do it. I do counsel against like having the TV on again because of the blue light that can affect the sleep.
Mm.
But if it's like a sound machine, and they're feeling like it's better for their sleep, I'm all for it in that sense.
It does speak to the idea of like association. Like, so if you're kind of like associating that for a child, like if the baby can only sleep with the sound machine on, that might be like kind of like creating these patterns of behavior for a newborn or a child that like would be a little bit harder to break, I would imagine, because they associate noise and sleep, and maybe that helps them, but also like can't sleep without my noise machine, right? Like I know people who are
Yeah.
like traveling with their noise machines because That's the only way that they can fall asleep. Um,
Mhm.
what did we miss? What did we not cover? What do you, and I really feel like, you've kind of walked right by the perimenopausal woman, which I think is such a conversation right now, especially I feel like finally people are discussing like, wait a minute, we pay attention a little bit more. Is there anything really, I understand the studies haven't been done yet, but like, is there anything related to perimenopause and sleep that you want people to know that might be different than sleep in a younger person or in a pregnant woman? Is there anything about this sleep that looks or feels different?
Yeah. So one of the things that I think with perimenopause is I think people just think perimenopause and are actually thinking menopause where they don't have that period for like over a year. But truly perimenopause can last anywhere from like 8 to 14 years in total. And you're having like constant hormonal changes during that time. So you don't know where anything is at. So that means a lot of variation. So maybe you started to have insomnia, which is actually one of the more common symptoms that you can have during the perimenopausal transition. And then you get hormone replacement therapy, it gets better. And then after some time, your hormone is doing all the changes at once again. And then you start having insomnia again. So
So
that's,
you really, so you have like a recurrence?
yes, you can have recurrence of insomnia during the perimenopausal transition. And a part of me
Huh.
thinks it's just because the hormones are keeping like adjusting until you reach that postmenopausal part. So that's part of it. Originally, like what people thought was the vasomotor symptoms of perimenopause. That's the only reason why we're
Hmm.
having insomnia during perimenopause.
Just
Now we know
just to
that's
just to clarify, vasomotor symptoms would be like the night sweats,
the
right?
night
Where
sweats and the hot flashes.
Mhm.
Yes. And now we know that's not necessarily true. Like there's other, components to it, including like the hormonal component to it. So I think like uh there's like this misconception of like if you treat the hot flashes, like everything will get better, but that's not the only symptom that's happening. So I think it's just more complex than that. But there's hormonal replacement therapy out there. There's new medications that are coming to treat the vasomotor symptoms that are not hormonally mediated. So I think we're on a good track, and we're
Okay.
starting to study sleep more in perimenopausal women, and we have some like off-label medicines which seem to be helpful for patients. On our group, which is not using a medicine, it's just using a behavioral intervention, is actually really helpful for my patients as well. So I think there's hope out there. I would say like there's hope out there for better sleep, and no matter where you're at in your reproductive journey as a woman, because there's so many changes, but there's always hope out there.
I love that. Tenny, what about you? What do you want to address to these perimenopausal women and this experience?
Yeah, I would say you're certainly not alone in what you're going through. And kind of like Glorisel said, it's not hopeless. And we can also treat it without necessarily knowing the exact reason. Because sometimes we get caught up in that, right? What
Mhm.
is the reason I'm feeling this way? And usually it's multifactorial. And even if we don't get down to what some of those factors are, we can still treat it. Somebody can still feel better, have a better quality of life if we don't figure out the one, the exact reason why they're feeling this way. And usually there's more than one. So
Yeah.
you won't find
Yeah.
that one thing.
I think also just like I want to just like mark here a moment of these experiences can be very distressing, right? That when these changes happen and as perimenopause progresses, and sometimes I think that we have some physicians who are better and skilled and some who are just not trained and knowledgeable, and often is kind of like these issues are brushed over. They're not addressed in the severity in which they may be experiencing it as a person. And it'd be like, okay, yeah, I'm having a hard time sleeping, but rather than be like, no, I'm having a hard time sleeping. Like this sleep is becoming a primary concern of mine if I'm, and nobody's paying attention, right? And that's the piece that I want to highlight, that like it's something you want to pay attention to. If this is causing you distress, this is causing you to feel badly about life right now, or feel, distress over, ask for help, like reach out. And I guess that's where I would like us to kind of close in. And I do want to ask you about, although you just said some misconceptions, so I like that. But where would you send people to look? Not everybody lives in Houston and can access Baylor, but where do you find good data, good research, good recommendations for women who are hearing this and want to make their own kind of foray into getting support and getting help? What are their options?
Yeah. One of the options that comes to mind is Sleep Project. I think it's supported by the American Academy of Sleep Medicine. And so just looking through them and their resources, I think that would be like a good place to start. And I would try and check if there's anyone that's like board certified in this. I would try and, if you want to do some kind of therapy, I would look for people that are board certified in this or like have a good training in this area to be able to help you through.
Fascinating. What about you, Tenny? What do you think?
Yeah, I would say, if they can search for providers in their area who provide cognitive behavioral therapy for insomnia, who have specific training, not just in cognitive behavioral therapy, but cognitive behavioral therapy for insomnia.
CBTI. Yeah.
Yeah,
Mhm.
CBTI, that would be really helpful. And there's not necessarily a ton of them, but they're out there, and they're
Yeah.
very good at what they do.
Amazing. What are let's start with you, Tenny. What is a misconception that you want to make sure that people recognize and are alert to?
The more you think and stress about sleep, the less likely you're going to sleep.
Okay.
So it's basically like the less space you let it take in your life, the better it is, which I know
Okay.
feels so counterintuitive because we like, as humans, we want to control everything, we want to fix everything, but this isn't always like that.
Interesting. Okay. How about you, Gloricel?
There's no such thing as perfect sleep.
Mm,
I don't think anyone wakes up in the morning feeling 10 out of 10 in their energy scale. I always say, like, be kind to yourself in the morning and also be nice to yourself at night. We have like a whole routine for babies when they're going to sleep. And I'm like, why don't we have routines as adults for ourselves and be more
mm,
kind? So I don't think there's perfect sleep, but we can definitely have better sleep and we can feel more rested and maybe allowing ourselves to have like a good bedtime routine that feels relaxing for us at the end of the day and like a slower morning instead of like, I need to rush out and wake up the kids and be ready in 30 minutes. That might allow us to also just feel a little bit better in general.
I love it. I love it. This has been a fascinating conversation. I feel like the research is only continuing to grow and emerge and I think that this dovetails very comfortably into everything that Postpartum Support International is yelling on the top of our lungs about how critical sleep is and how sleep is protective of mental health and a crucial part of, especially bipolar care in postnatal women and perinatal and postpartum women. And like, I think the more we can understand the science of it and the data of it, the better we serve the people that are needing our support. So thank you so much for this conversation. This has been fantastic.
Thank
Thank you
you.
so much for the invitation. We appreciate it.